The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So let's now go to infertility. So questions about infertility. Prolactinoma associated with infertility is included in what WHO group of ovulatory dysfunction. So natatanong yan sa boards ang WHO group of ovulatory dysfunction. So i-memorize natin yan. Okay, second question. First line of treatment for a 40-year-old woman with infertility. Okay, tingnan natin. Nakita natin 40-year-old. So definition of infertility, it's the failure of couple to conceive after 12 months of unprotected sexual intercourse. Unprotected, regular sexual intercourse. Sana all may regular sexual intercourse. Ano ba yung regular? It's at least 3 to 5 times in a week. Hindi, at least 3 times a week lang pala. No? Kasi pwede namang maraming times. At least 3 times in a week. So yun, regular sexual intercourse na yun. Indications for investigation of infertility is those na 35-year-old ang woman with no pregnancy after 6 months. Kasi yung mga 35 years old, they have a higher risk for infertility talaga. So 6 months pa lang, kahit wala pang 1 year, pwede nang magpa-work up. There's oligo or amenorrhea, no? Pag may PCOS, yan ang usually nangyayari dyan. So kailangan ina-address din yon. There is tubal obstruction. Of course, if there's tubal obstruction, there are risks for ectopic pregnancy and infertility. Kasi saan ba nagkakaroon ng fertilization? Sa fallopian tubes. There is uterine disease. Okay? Severe endometriosis, kasi endometriosis can cause mga adhesions, no? Syempre, ayaw naman ng baby, ng embryo mag-implant sa hostile environment, no? With endometriosis. Inflammatory, ano rin yan? Inflammatory process din ng endometriosis. So, parang nakikita ng zygote na walang mangyayari sa kanya. Okay? And known male factor. The causes of infertility, usually ang sinisisi natin, no? Pag infertile is the babae. Actually, halos pareho lang ang percentage ng cause of infertility between male factors and female factors. Mas mataas lang ng konti sa female factor. Okay, 35% male only, 45 to 55% female factor only, 10 to 20% combination male and female factors, and 10% unexplained infertility. Okay, this came from blueprints. Ito yung mga natatanong sa mga previous board exams sa mga percentages on infertility. Ito yung contribution of various male and female factors to the incidence of infertility in 2014 pa to na study. Pero ito pa rin yung nasa blueprints. Male factor include hypothalamic pituitary disease, testicular disease, post-testicular defects in sperm transport, or idiopathic. Pag female factor, ang pinakamalaki dyan is ovulatory or ovarian factors, followed by peritoneal or tubal factors, endometriosis, uterine and cervical factors, or multiple, sama-sama na female factors. Okay, so ito yung nasa table, ito ang nasa graph. Okay, alam niyo naman ang blueprints, no? Ito naman is fecundability. Fecundability is the ability to achieve pregnancy in one menstrual cycle and is a more accurate measurement to evaluate fertility potential. So, ibig sabihin, in one cycle, no, in 1 month, 20% of couples become pregnant. 6 months, no, 60%. 9 months, 75%, 12 months, 80%, 18 months, 90%. So the longer you are together, the more chances of conceiving. So that's fecundability. This is different from fecundity. Fecundity naman is the ability of that pregnancy to result into a live birth. Okay, so yung fecundity, lagi siyang mas mababa than fecundability because of factors like miscarriages, no? O kaya preterm birth, death, yung mga ganyan. Kailangan live birth. Okay? Intrauterine fetal demise pala, sorry. Yun yung mga factors na yun. Kaya mas lower ang fecundity than fecundability. Yung nasa handout nyo, paki-correct po, next 9 months is 75%. Okay, this is fecundability. First 3 months is around 20 to 25%. Next 9 months is around 75%. Okay? So let's look into the different factors, no, of female infertility first. Yung ovulatory or ovarian disorders, diba ito yung pinakamadami? Ang ovulatory ovarian disorders according to the WHO is grouped into 4. Yung first one is hypogonadotropic hypogonadal anovulation or hypothalamic amenorrhea because there's a problem with GnRH pulsatility. Okay? Yung group 2, ito yung PCOS, normogonadotropic. So normal ang gonadotropins, normal ang estrogen, no? Pero anovulatory pa rin siya. It's probably because of PCOS. Yung group 3 is hypergonadotropic hypoestrogenic anovulation such as their primary ovarian insufficiency or decrease na yung ovarian reserves. Yung group 4, yung hyperprolactinemic anovulation. So that's group 4. Kung ako, itong table na to, madali lang naman siyang tandaan. Okay? Kung gusto nyo, i-memorize nyo lang yung 1, tsaka 2, tsaka 4. So, parang lahat na, Doc. 'Di ba? Basta kung wala dun sa 3, nandun yun, ay wala dun sa 1, 2, and 4, nasa 3. Okay? So, medical management of an ovulation, of course, you give fertility induction drugs or ovulation induction drugs in the form of clomiphene citrate. That's the first line. Okay? Another first line is letrozole. Letrozole is used nowadays because of its cost effectiveness. Okay? Pero pareho lang naman din sila, yung clomiphene citrate tsaka letrozole. Ito lang ay galing sa blueprints. Okay? Yung letrozole nandito sa dulo. Okay? So you can also give metformin because it inhibits gluconeogenesis. It's an insulin sensitizer. Ano nga ang pathophysiology natin ng PCOS? 'Di ba sabi natin kanina, it is insulin resistance. So to improve that sensitivity of insulin, we give metformin, no? Kaya pag nakikita niyo yung mga OB nagpe-prescribe sila ng metformin for those with PCOS because it's an insulin sensitizer. Okay? Another female factor infertility factor are tubal factors. Okay, kasi nga saan ba fertilize? Okay? Nag-fertilize yan, fertilization happens at the fallopian tube. So kung may problema sa fallopian tube, walang fertilization na nangyayari. Like yung tubal diseases mo. Okay? Pelvic adhesions results in infertility by preventing the transport of the sperm to the oocyte through the fallopian tube, which is usually caused by PID. So, ang pelvic inflammatory disease can cause also infertility. Usually yan, since it is an ascending infection sa PID, na-occlude niya ngayon, no, nasisira yung fallopian tubes. Okay? So, pwedeng mag-microsurgical tubuloplasty, okay, with tubal reanastomosis or neosalpingostomy, no, or IVF, diretso na sa uterus. Pag hydrosalpinges, salpingectomy, then IVF. Ito yung endpoint ng PID, hydrosalpinges. Okay? Pag caused by infection from prior tubal ligation, ito yung gagawin. So basically, pag sira yung tubes mo, you have no choice but to do IVF. Okay? This will just show you hysterosalpingogram. Okay? Kung paano siya ginagawa. Nag-i-insert ng dye, okay, tapos ini-x-ray, no, hysterosalpingogram. Yan, salpinges, tinitingnan kung patent ba ang fallopian tube. Pag may spillage ng dye here, kung may spillage ng dye, makikita yan. Ibig sabihin patent. Kung walang spillage of dye into the peritoneum, ibig sabihin barado yung fallopian tube. Next are uterine or cervical factors. For the uterine factors, you can have uterine synechiae, septate, polyp, no, or submucosal fibroids. Okay, so you treat them by operative hysteroscopy, sisilipin, magmamayomectomy, especially if there's recurrent pregnancy loss or may fibroids na identify. Cervical factor, syempre pag may Mullerian duct abnormalities or cervical stenosis, no, mahihirapan din ang sperm to penetrate. So there's intrauterine insemination. If refractory to this, IVF. Endometriosis, again, this can invade local tissues and cause severe inflammation and adhesions. It can interfere with tubal motility, causing tubal obstruction or result in tubal or ovarian adhesions na nagko-contribute dun sa infertility as we've discussed kanina. There is no treatment talaga for endometriosis na medical management, unlike mga ovulatory dysfunction. Okay, surgical yan. By resection, by ligation of the implants, o kaya adhesiolysis. Okay, so yun yung mga ginagawa for endometriosis ng mga infertile na women. Male factor infertility, ang kailangan nyo lang tandaan dito, varicocele, because it is the most common reversible cause of male factor infertility and is repaired by ligation. Laligate lang yung mga vessels. Okay? It's a structural factor, varicocele, testicular torsion, or syempre nagpa-vasectomy na. Okay? So, ito yung mga common, abnormal yung semen, may endocrine disorder, environmental exposure. So, pag nag-evaluate kami ng infertile couples, we ask, do you smoke? Do you drink alcohol? How much? No? Pwedeng genetic, pwedeng may sexual dysfunction, or pwedeng unexplained. Okay? How do you diagnose male factor infertility? Isa lang, semenanalysis. Okay? It's a primary investigative tool for male factor infertility. The semen sample is analyzed for sperm count, volume, motility, and morphology, pH, and white blood cell count. In cases of abnormal semenanalysis, pinaulit mo na abnormal talaga, an endocrine evaluation is necessary. So, Doc, paano ba ang semenanalysis ng lalaki? Usually, pag nag-explain ako sa patient, gaganon ako. 5. Diba? Dito, magsisex kayo. Tapos 2, 3, 4, hindi kayo magsisex. So sa 5th day, magpapasemenanalysis na siya. So dapat merong abstinence ng at least 3 days to get the proper semen sample. Okay? Yung endocrine evaluation naman, assess for parenchymal damage of testes or hypogonadism. In cases of azoospermia, pwedeng i-karyotype or Y chromosome microdeletion genetic testing. Bakit, Doc, inuuna ang in evaluation of infertility, ang inuuna talaga dyan is sperm analysis, or semenanalysis. Yun talaga yung inuuna. Kasi yun yung evaluate, kung azoospermic talaga siya, wala nang magagawa yung female. 'Di ba? Pwede siyang mag-donor sperm. So hindi na sa lalaki yun, hindi na sa asawa niya yun. Okay? Kahit na anong evaluate mo ba sa female, kung wala namang sperm, yun yung pinakamadali, 'di ba? Kung wala talagang sperm, wala talaga tayong magagawa. So this is just the algorithm of evaluation and of treatment. You do history and PE. Pag normal yung semenanalysis, doon maraming mga mangyayari. Yung female factor infertility naman ang i-check natin. Pag abnormal, if azoospermic, again, donor insemination. If subnormal, repeat semen analysis. If persistently subnormal, you may refer to urologist. So ito yung algorithm of evaluation of treatment. So balik na tayo sa question natin. Prolactinoma, anong group? WHO group 4. First line of treatment for a 40-year-old woman with infertility, this is actually IVF. 40-year-old na siya eh. Okay? So pag natanong lang, the first line is IVF. Now, let's go to menopause. So hindi mabuntis sa tapos na ang reproductive potential, So menopause. Question. The only clinical indication for menopausal hormone therapy. So ano ang only indication for MHT? Let's define some terms first. When you say climacterium, this is from reproductive stage to non-reproductive stage. So yung buong period na yon, that is climacterium. When you say perimenopause, it's the transition from normal ovulatory cycles to menopause. So pakonti ng pakonti yung mga cycles niya. until mag-reach ng menopause. Menopause is 12 months of amenorrhea after the final menstrual period in the absence of any other pathologic or physiological causes. Okay? Menopausal transition or your perimenopause. This may take years prior to menopause that encompasses the change from normal ovulatory cycles to cessation of menses. The hallmark of perimenopause are skip periods or longer intervals. And symptoms can begin from 2 to 8 years prior the FMP. Dito rin, during perimenopause, na-experience ng mga patients ang vasomotor symptoms, including night sweats, daytime hot flashes and flushes, same lang, mood swings, including irritability and depression, insomnia, and sleep disturbances. Okay? During perimenopause, naguguluhan yung mga hormones, no? The hormonal level during perimenopause, yung inhibin B is decreased, your FSH is increased kasi wala na siyang nasi-stimulate na follicle eh. So dahil walang estrogen masyado, so tataas yung FSH mo. The progesterone is low, the estradiol fluctuate, but generally are preserved until late in the perimenopause when both estradiol and FSH can fluctuate. Okay? It's perimenopause. Menopause, again, 12 months after the FMP, characterized by complete or near complete ovarian follicular depletion and absence of ovarian estrogen secretion. So the average age is 51 years old. How do you diagnose? With the history, 48 to 52 years old, no? Average is around 51. Physical examination, lahat ng mga ginagawa ng estrogen nawawala na. Decrease in breast size and change in texture, mag-i-increase yung abdominal circumference, gain in the upper abdominal weight gain. There's vulvovaginal atrophy, dryness of the vulvar area, increase in the BMI, there's skin changes, loss of elasticity, hair changes, dry eyes. But the endocrinologic marker for menopause is FSH levels greater than 40 IU per liter. Again, this is the endocrinologic marker. More than 40 IU per liter, mataas ang FSH kasi wala na siyang follicle na nasi-stimulate, so nag-accumulate siya. Okay? This is also our mnemonic for the symptoms and long-term effects of menopause. FSH more than 40 IU per liter. F, flushes, forgetfulness. S, sweats, mga night sweats, sad, stroke, skeletal changes, bone loss, skin changes, sexual dysfunction. H, headache, heart disease, wala na yung estrogen, na protective from heart disease. I is insomnia. U, urinary symptoms, including urogenital atrophy. Okay, L is libido decreases. There's such a thing as genitourinary syndrome of menopause or GSM. This include vulvovaginal atrophy, dryness and itching, discharge, dyspareunia, urinary system changes, such as incontinence and dysuria. So how do you manage menopause? May drug therapy, hormonal in the form of estrogens and progestins. Wala kang estrogen, bigyan mo estrogen. Okay? Low-dose estrogen and progestins, tibolone, and LNG-IUS. So pwede mong ibigay ang hormonal therapy na yan. Okay? Treatment options for menopausal symptoms for cardiovascular changes. Of course, you give the BP and lipid control medication, smoking cessation, weight loss, and exercise. Osteoporosis prevention, hormonal replacement therapy, calcium, vitamin D, biphosphonates, calcitonin serums. Okay, pwede mong ibigay yan lahat. For hot flashes, MHT, SSRIs, SNRIs. For genital menopausal symptoms, vaginal dryness, dyspareunia, incontinence, and dysuria, pwedeng low-dose vaginal estrogen or water-based lubricant or vaginal moisturizers. For mood disturbances, MHT. Pero sabi sa blueprints, okay, the only clinical indication or treatment, kasi these are all supportive, pero treatment for MHT is for moderate to severe vasomotor symptoms or hot flashes. So, dun mo siya pwedeng ibigay. Okay? Okay. Now let's go to osteoporosis. What is the recommended dose of vitamin D for women at risk for osteoporosis? So, ano ang recommended dose ng vitamin D? Iba-iba yan, kahit sa pregnant iba. Okay. Risk factors, mnemonic for osteoporosis is shattered. Okay? Shattered. Ang pinaka-shattered family. Okay? Family history and age are the major determinants of lifelong bone density. Okay? Again, family and age are major determinants of lifelong bone density. So, ito yung shattered. Steroid use, hyperthyroidism, alcohol, thin, no? So, kung medyo payat ka, pwede kang mas at risk ka kesa sa akin. Testosterone low, early menopause, renal or liver failure, erosive inflammatory bone disease, no? Dietary calcium low, and family. Okay, so how do you screen? You screen with bone mineral density screening. No, this should begin at age 65 years old for all women. Postmenopausal women under the age 65 should be screened if they have significant risk factors, including history of fragility fracture, weight less than 127 pounds, parent with a history of hip fracture, current smoking, alcoholism, or rheumatoid arthritis. The gold standard for the diagnosis is DXA of the lumbar spine and hip. Okay? How do you treat? Lifestyle changes, weight-bearing exercises, adequate calcium and vitamin D intake, okay? Reduction in active and passive smoking and alcohol intake, medications for prevention. This is just to prevent biphosphonate, zoledronic acid, raloxifene, and MHT. Medications for treatment can be biphosphonate, SERMs, denosumab, calcitonin, and parathyroid hormone. Okay? Recommended dose of vitamin D, it's 600 milligrams, 800 milligrams for those 71 years old and above. Okay? Again, 600 milligrams for the general population, 800 milligrams for those 71-year-old and above. I think this is from comprehensive gynecology. Let's now proceed to the benign disorders of the lower genital tract. Ano ba yung mga lower genital tract natin? 'Di ba? Perineum, outer tract, no? Hanggang cervix. Okay, let's now go to benign disorders of the lower genital tract. Okay, ano ba hanggang saan ba yung lower genital tract? From the vulva to the cervix. So, yun hanggang cervix. Alright, Bartholin's gland. Ano ba itong Bartholin's gland? Naririnig nyo to, nakikita nyo to sa ER, yung mga Bartholin's gland abscess. So, the Bartholin's gland is located at the entrance of the vagina from at the 5 to 7 o'clock position. Okay, 5 to 7 o'clock. Sabi nung iba, 4 to 8. So, Bartholin's gland pa rin yun, no? The duct is approximately 2 cm long and open into the groove between the hymen and the labia minora. So, medyo nasa loob siya between the hymen and labia minora in the posterior lateral wall of the vagina. Most common, it is the most common large cyst of the vulva. Again, most common is Bartholin's gland cyst. May nangyayari dyan sa cyst na yan. Pag nai-infect, nagiging abscess. Alright, pag cyst, it is tense. Pag abscess, it develops rapidly from the cyst. It becomes erythematous, tender, and has edema. If it's just a cyst, it is non-painful. But if it's an abscess, no, acute vulvar pain, dyspareunia, and pain during walking. Kasi abscess na siya, hindi siya makalabas doon eh. Okay? So, pag meron sa ER na parang naglalakad, na sakit na babae, naghuhulaan na yan ang IM, ang surgery, at saka yung OB. No? AP ba yan? No? Ruptured AP ba? Ectopic ba yan? Or Bartholin's ba yan? Okay? Usually, pag ectopic, di na makapaglakad. Okay? Kasi hypotensive na yon. So, nag-iisip na yan. So, pag sinabi na ng patient na parang meron po siyang cyst sa puwerta, so, ang naiisip na, OB, go na. So, yung OB na yung mga pupunta. No? So, naguhulaan dyan. Kasi pareho ng itsura yung AP at saka yung Bartholin's gland abscess, no? Kasi painful rin talaga yan. How do you treat? Pag cyst, no treatment. Pag wala namang symptoms, can have sitz bath for pain relief to decrease healing time. For abscess, we do word catheter placement. It's just an office setting, yung balloon tip, placed inside the cyst and inflated and left for around 4 to 6 weeks. Marsupialization, no, ito yung ginagawa talaga natin for Bartholin's abscess. Yung entire cyst or abscess is incised and sutured to the vaginal mucosa. Or if the woman is older than 40 years old, to rule out adenocarcinoma, or for recurrent Bartholin's duct cyst or abscess, we do excision biopsy. Again, 40 years old and above. Okay, we also give antibiotics for gonorrhea or staph aureus for this. Doc, bakit hindi na lang mag-excision biopsy para matanggal na lahat? 'Di ba? Bakit pa magma-marsupialization? Okay, this is the vulva we are talking about, no? Nakita nyo na ba kung gaano ka dugo, no, ang vulva pag ini-incise. So, kung halimbawa makaka-get away naman with marsupialization, kung kaya naman mag-marsup, no, i-drain lang yung mga abscess, go, i-marsup na lang natin yan. I-open lang yan para mag-drain yung mga abscess. Okay? Kasi pag excision biopsy, madugo talaga yan. Meron akong patient dati, actually kung patient ng consultant, nag-assist lang ako. Ang nangyari, marsup lang yun dapat. No? Marsup lang. Pero parang na-convert siya into excision biopsy to the point na kailangan namin mag-transfuse ng dugo sa sobrang dugo niya. Okay? Sa sobrang dugo, hindi namin mapastop yung bleeding. So, ang na-realize ko nun, dapat prepared ka rin for excision biopsy kahit marsup lang yung plinano mo. Okay? So, yun lang naman. So that's for Bartholin cyst. Now let's go to the cervical lesions. We have your cervical polyp and Nabothean cyst. Ano bang difference nila? Cervical polyp, no? Cervical cysts muna tayo. For cervical cyst, we have Nabothean cyst, mesonephric cyst, and endometriotic cyst or endometriosis. Ang endometriotic cyst, apologies, ang endometriotic cyst ay cyst na ang endometriosis na nasa ovary. Pag sinabing mong endometriotic cyst, nasa ovary. For all the other parts, they are just endometriotic implants. Okay? Nabothean cyst, these are mucus-filled retention cyst. So, wala namang ginagawa dyan. Ganyan lang ang itsura niya. It is caused by intermittent blockage of endocervical gland that they usually expand to no more than 1 cm in diameter and require no treatment. So, nakikita lang yan, no? Sa ultrasound, minsan mababasa mo na both yan cyst present, tapos nagpapanik na yung patient kung bakit daw siya may cyst. No? Just have to reassure them that these are just retention cysts na wala namang ginagawa doon. Mesonephric cysts are remnants of Wolffian ducts that can become cystic. They tend to lie deeper than your Nabothean cysts. No? And on the external surface of the cervix. Ang endometriosis, ganyan yung itsura niya. Para siyang blood. 'Di ba? It can implant near or on the cervix, red and purple in color, and the patient will often have associated symptoms of endometriosis, such as cyclic pelvic pain and dyspareunia. Okay, so those are your cervical cysts. Cervical polyps and fibroids naman are these. Ang difference nila, pag polyp, benign growths that may become pedunculated or sessile. Ano nga yung difference ng polyp sa fibroids? Central yung vascular channel, single central feeding vessel. No, ang cervical polyp. Ang fibroids or cervical myoma, there's peripheral vascular channel. You manage polyps with polypectomy or electrocautery for large polyps or hysteroscopy, no, to differentiate endocervical from endometrial polyps. Baka nag-prolapse lang yung endometrial polyp kaya kala mo endocervical, no? Tas hindi mo makapa yung base kasi endometrial polyp pala siya. For fibroids, depende, no, sa age ng patient, sa fertility potential, you can either do myomectomy or hysterectomy. Yan. Now let's go to the benign disorders of the upper naman, upper genital tract, so uterus up. So first off, I would just like to tell you, no, the terminologies of aberrant endometrial and myometrial tissues. Okay? Pag sinabing adenomyosis sa palm coin, ito yung sa palm coin, sa AUB, ito yung AUBA, no, adenomyosis. It's the presence of endometrial tissue in the uterine myometrium. Okay? Yung endometrium, dapat nasa endometrium lang siya, pero nagpunta na siya ng myometrium, leading to abnormal bleeding and pain. Okay? The uterus becomes soft and globular. So, pag gyne ang tanong, tas na sinabi nila the uterus soft, globular, okay? Think of adenomyosis. Okay. You treat this by progestin-containing IUD, okay, or hysterectomy, which is the most effective treatment. Actually, in the prior years, before the advent of high-tech ultrasound, okay, malalaman mo lang na may adenomyosis yung patient pag hysterectomy mo na siya. It's a histologic finding. the adenomyosis. When you say naman adenomyoma, there's a well-circumscribed collection of endometrial tissue within the uterine wall. Nasa myometrium pa rin siya. This may contain smooth muscle cells and are not encapsulated. Adenomyomas can also prolapse into the endometrial cavity similar to a classic endometrial polyp. Okay, so adenomyosis, iba yun sa adenomyoma, no? Iba yun sa endometriosis. Endometriosis is presence of endometrial cells outside na of the uterine cavity. The hallmark of this chronic disease is cyclic pelvic pain. These are estrogen-sensitive lesions and can be treated with NSAIDs, OCPs, progestin, GnRH agonist, or surgery for endometriosis. When you say endometrioma or endometriotic cyst, this is a cystic collection of endometrial cells naman, old blood, and menstrual debris on the ovary. It is also called chocolate cysts. Okay? When you say leiomyoma, these are local proliferation of smooth muscle cells within the myometrium, often surrounded by a pseudocapsule, also known as fibroids. These benign growths may be located on the intramural, subserosal, or submucosal portions of the uterus. Okay? So, benign disorder, pelvic endometriosis. Again, these are presence and growth of glands of the endometrial lining in an aberrant location. Classic symptom of pelvic endometriosis, cyclic pelvic pain. Okay? Other symptoms, infertility, dyschezia, dyspareunia, and dysuria. The ovaries are the most common location of endometriotic implants. The theories regarding endometriosis, the pathogenesis of endometriosis, ang pinaka-widely accepted is retrograde menstruation or the Samson theory. There's reflux of menstrual blood and viable endometrial cells in the pelvis. Pwede rin siyang metaplasia during epithelial development. No? Yung coelomic epithelium retains the ability for multipotential development and invaginates into the ovarian cortex, which leads to ovarian endometriosis. So that's metaplasia. Pwede ring lymphatic and vascular mets, which is the Halban theory. It explains the rare and remote sites of endometriosis, such as the spinal column and the nose. So, merong mga patients na may endometriotic implant sa nose na every time nagkakaroon ng monthly cycle, no, nagno-nosebleed rin sila. Okay? So, that, the theory of Halban, no, explains that. Ang pinaka-weird site na nakita ko is sa tuhod. Okay? Yung endometriotic implant niya nasa knee. So, nung nag-menopause na siya, nawala na yung implant na yon. Iatrogenic dissemination may also happen during CS, no, or during pelvic surgery or uterine surgery, yung endometrial glands and stroma na i-implant during these procedures. Okay? Kaya siya iatrogenic. Immunologic changes. There is hyperactive monocytic type macrophages in the peritoneal fluid that secretes multiple growth factors and cytokines that enhances the development of endometriosis. Okay? Or genetic predisposition. Sinasabi nila if you have a family history of endometriosis, more likely you too will have endometriosis. So the classic symptom of endometriosis is again cyclic pelvic pain and infertility. Common symptoms ang pelvic heaviness, dyspareunia, abnormal bleeding, or GI and urinary tract symptoms. No? Clinical findings, classic pelvic finding is a fixed retroverted uterus with scarring and tenderness posterior to the uterus. So fixed ang cul-de-sac, hindi siya gumagalaw. Okay? So, makakapa mo yung mga implants when you do rectovaginal exam. Okay? The diagnosis of which, the gold standard, is laparoscopy. No? Ultrasound and MRI, pwede mong makita, especially if it's an endometrioma. Okay? Pero kung yung mga implants sa pelvic implants, hindi mo siya makikita sa ultrasound. How do you manage now endometriosis? The primary goal is induction of amenorrhea. Okay? So, magkakaroon ng pseudomenopause effect. Pwedeng mag-anti-androgen, hyperandrogenic effects such as urdanazole. Pwedeng medical oophorectomy with GnRH agonist. Okay? Or pseudo-pregnancy state with high-dose OCP. Okay? This is the management. These are the recommended strategy for management of women with endometriosis and pain symptoms. Okay, you can give oral contraceptive pills with or without NSAIDs, a GnRH add back, plus an add back for to prevent bone loss. And you may reconsider, kung wala pa ring improvement, reconsider other diagnosis. Or you can go to laparoscopy or for appropriate therapy. Okay? Pag may improvement naman, no, you continue therapy. Pag may adnexal mass, you do imaging, no, surgery or suppression or observation. Depende sa type ng mass. No? Now, let's go to the uterus naman. Endometrial polyp, leiomyoma, and adenomyosis. So, these are the benign lesions of the uterus. An endometrial polyp, again, localized overgrowth. Okay? Yung kanina, ang diniscuss natin, cervix, cervical polyp. Ito naman, endometrial polyp. Okay? It may be asymptomatic. Management is hysteroscopic removal. For leiomyoma in the uterus or fibroids, no, yun yung signs and symptoms natin. You do myomectomy or hysterectomy. For adenomyosis, aberrant glands of basalis layer of the endometrium. Yung classic symptom niya is dysmenorrhea and menorrhagia, heavy bleeding. No? Ang classic pelvic exam, diffusely enlarged uterus. There is no medical management. No, you just do hysterectomy for adenomyosis. Excuse me. Now, let's go to endometrial polyp. These are localized benign overgrowths of endometrial glands and stroma over a vascular core. Diba? Vascular feeding vessel, central. Clinical manifestations is AUB. The presence of endometrial polyp can be seen in pelvic ultrasound. The size is sonohysterogram. Number of polyps, hysteroscopy na. You treat it by removal of polyp either through hysteroscopy or combined procedure DNC. Pero ang gold standard is hysteroscopy. Now, leiomyoma, diba? Leiomyoma or myoma or fibroids can be either submucosal, intramural, or subserosal. The symptoms we've mentioned kanina, fibroids. Frequency and retention of urine, hydronephrosis. I, for iron deficiency anemia because of the bleeding. B, bleeding abnormalities. R, reproductive difficulties. O, obstipation and rectal pressure, especially if this is subserous, kasi lumalaki sila. Kung anterior siya, na-impinge na yung bladder. Pag posterior siya, na-impinge na yung rectum. Okay? Infertility also, dysmenorrhea and dyspareunia, and S, symptomless, which is the most common. Di mo alam na may myoma ka na pala. The leiomyoma can undergo degenerative changes. Pwedeng hyalin, which is 65%. Carneus or red, this occurs in 5 to 10% of pregnant women. So, kung nahihirapan magbuntis, no, if there's subinfertility for those with myoma, pwede rin na mabuntis sila, tapos mahirapan sila because nagde-degenerate yung myoma. So, yung dating painless na myoma, pwede ngayon mag-cause ng pain because it degenerates. Okay? Dun sa mga buntis. Kasi remember, ano ba ang pagkain ng myoma? Estrogen, 'di ba? Pag buntis ka, mababa yung estrogen mo. Hindi naman ganun kataas. So, nagde-degenerate. Quote, parang nabubulok. No? Parang ganon ang degeneration ng myoma. So, nagkukos yun ng pain. No? That's carneus or red degeneration. Pag calcific, no, pag medyo tumatanda na, necrosis ng tissue, cystic or hydropic, fatty, and malignant. This is a misnomer actually, malignant changes, kasi once it's a myoma, it's just a myoma. It is benign. Okay? Rare or hindi nangyayari, no? Kung yung malignant na, kung yung myoma na benign naman talaga, pwedeng mag-transform or mag-degenerate into a leiomyosarcoma. Okay? Or whether they just arise spontaneously, yung leiomyosarcoma. How do you manage? Ang mnemonic natin dyan is go Pan-Am. Okay? Conservative, of course, is myomectomy. Definitive treatment is hysterectomy. Go Pan-Am, pwedeng GnRH agonists. O, oral contraceptive pills. P are progestins. A is antifibrinolytic. N is nonsteroidal inflammatory for pain. A is androgenic steroids. M is mifepristone. Okay? Surgical procedures. Pwedeng uterine artery embolization. MRI, focused ultrasound surgery, myomectomy, and hysterectomy. So this is an example of a myoma. I think this is a subserous myoma. No? Yan yung itsura niya. Indications for surgical interventions. Okay, pag AUB causing anemia, severe yung pelvic plane, uncertain if the mass is benign, no, or other type of tumor. If there is already urinary frequency, retention, hydronephrosis. There is growth after menopause kasi wala ka na nga estrogen nun, bakit pa siya nag-grow. Recurrent miscarriage or infertility, especially for submucous myoma, and there is rapid increase in size. So that is leiomyoma. Adenomyosis, again, we've defined this kanina as opposed to your adenomyoma. Okay, the management for adenomyosis is hysterectomy. That's the definitive for adenomyoma. Okay, you can remove this. Okay, usually, ang ginagawa rin dito is hysterectomy. That's the definitive treatment for adenomyoma. Okay? Adenomyosis, ultrasound characteristic, di ba sabi natin kanina before, ang adenomyosis, ang definitive way lang to diagnose it is through histology. So dito, histopathologic finding. Dito naman, ito yung will give us a clue na we're dealing with an adenomyosis. So baka maitanong lang to sa inyo, no? There's spherical hypoechoic or heterogeneous uterine mass with pseudocapsule that is well defined, and there is acoustic shadowing or Venetian blind shadowing. Ayan, no? Dapat wala yung mga hypoechoic na mga lines na yan. So Venetian blinds pattern ang tawag dyan. Okay? So, tapos na tayo sa uterus. Let's now go to ovarian cysts and adnexal masses. So, you have your functional cysts. No, your functional cysts include follicular cyst, corpus luteum cyst, fecal lutein cyst, and endometrioma. When you say follicular cyst, failure of the follicle to rupture during follicular phase. Wala, kasama lang niya yung ovum, silang dalawa. No, hindi siya nag-rupture, hindi siya nag-ovulate. So this may vary in size from 3 to 8 cms, usually asymptomatic, but can lead to ovarian torsion when greater than 4 cms, and this may resolve spontaneously. Corpus luteum naman, failure of the corpus luteum to regress after 14 days. It becomes enlarged or hemorrhagic, no? And can cause delay in menstruation and dull lower pain. Kasi hindi nag-rupture yung corpus luteum mo, hindi siya luteolysis. Fecal lutein cysts naman, these are large bilateral cysts filled with clear straw-colored fluid because of abnormally high beta HCG. Usually sa mga molar pregnancy, may fecal lutein cysts. Wala naman ding ginagawa dito. Okay? Nawawala lang yan mag-isa. Alright? For endometrioma naman, again, this is endometriosis of the ovary. No, chocolate cyst yan. Meron yan symptoms of endometriosis. So how do you evaluate functional cyst? First, again, you do pregnancy test kasi hindi nagre-regla yan, 'di ba? Dahil yung mga functional cysts pinaprevent nila yung menstrual cycle ng maayos. Okay, so pregnancy test, very important. CBC, screening for gonorrhea and chlamydia, and for UTI as indicated. You do TVS, CT scan or MRI. No, these are reserved for secondary evaluation concerning abdominal processes, complex yung masses, or suspected malignancy. Pag hindi naman, okay na yung TVS. CA125 is obtained from patients who are at high risk for ovarian cancer. So ito galing to sa blueprints, management of cystic adnexal masses. Pag premenarcal na any type, more than 2 cm, surgical evaluation. Okay? Kung may cyst ka sa ovary. Pag reproductive, simple, less than 5 cm, no follow-up necessary. No? Pag 5 to 7, repeat ultrasound in 1 year. Pag more than 7, further imaging or surgical evaluation if no change. Okay? So again, yung size ng cyst ang tinitingnan natin dito. Pag hemorrhagic, less than 5, no follow-up necessary. Pag more than 5, repeat ultrasound in 6 to 12 weeks. So around 3 months. Pag endometrioma, any size, repeat ultrasound. Then if not surgically removed, follow yearly. Okay? Follow up yearly. Nodule without flow or multiple thin septations. Pag sinabing flow, Doppler flow, blood flow, no? Any, pwedeng MRI and or surgical evaluation. These are for reproductive patients. For postmenopausal, simple, less than 1 cm, no follow-up necessary. Pag 1 to 7, repeat ultrasound in 1 year. Pag more than 7, further imaging or surgical evaluation. Pag hemorrhagic, any early menopause, repeat ultrasound rin. Pag late menopause, surgical evaluation. nodule without flow or multiple thin septations, any, surgical evaluation or MRI. Okay? So, yun yung cystic adnexal masses. Again, cystic lang sila. Hindi sila complex masses. Okay? Hindi sila solid and cystic at the same time. Just cystic masses. Now, let's go to ovarian tumors and ovarian cancer. So, yun yung mga cysts. Ito yung mga tumors and cancer. So, benign and malignant ovarian tumors, we have, pag sinabi sa exam nyo na low malignant potential, okay, mga LMP tumors, those are borderline tumors. Hindi mo sila makonsider as malignant. They are low malignant potential tumors, LMP tumors, or borderline tumors. Okay? Pag epithelial, ito yung mga, designation. Okay? Pag epithelial, can be serous or mucinous. Ang benign na serous tumors ng epithelial origin, serous cyst adenoma, adenofibroma, and cyst adenofibroma. Borderline serous tumor. Ang malignant niya is serous cyst adenocarcinoma. Okay? Pag mucinous cyst adenoma. Brenner tumor, no, is also borderline tumor. Borderline mucinous tumor, mucinous cyst adenocarcinoma ang malignant counterpart. Ang Brenner tumor, no, borderline. Ang malignant endometrioid carcinoma, clear cell adenocarcinoma, or undifferentiated carcinoma. So, epithelial and then germ cell. Pag germ cell, teratoma. Pag benign cystic teratoma or dermoid cyst or solid teratoma. Okay? Ang malignant niya is monodermal or specialized, dysgerminoma, EST, choriocarcinoma, embryonal carcinoma, polyembryoma, and mixed germ cell tumor. Okay? So, ang pinanggalingan nila are either epithelial or germ cell. So, sabi naman sa blueprints, differences between benign and malignant masses on PE. So, on PE pa lang, may isip mo na kung benign ba yon or malignant. Sabi sa sabi sa blueprints, benign masses are usually mobile, cystic, smooth, and unilateral. Pag malignant, they are fixed, solid, irregular, and bilateral. So, makukita mo to with rectovaginal exam. Mararamdaman mo naman yung mga yan. Okay? Pag ultrasound naman, ang pagbabasihan mo, benign tumors are usually 8 cms or less. They are cystic. There are no solid components present. The septations are either isa lang or wala. There is no blood flow. Kasi syempre pag malignant, mas maraming blood flow, di ba? There is no blood flow when doing Doppler. Usually unilateral, and there is calcification, no, especially teeth. Kasi ang naisip mo dyan, baka dermoid naman yan. Dermoid or teratoma, no, makakakita ka ng mga teeth, ovarian tissue, adipose, hair, yan. Pag malignant, it is usually more than 8 cms. There are solid or cystic or solid components. Nodular or papillary, may mga papillary lesions ka na nafe-feel. It is multilocular or thick yung septations. There is present in the solid component yung blood flow, usually bilateral, and there is ascites peritoneal masses and lymphadenopathy. Okay, so ito yung makikita mo sa blueprints. The risk factors naman for ovarian cancer, okay, ang sinabi ko nga kanina, no, na ang pathogenesis ng ovarian cancer is a history of long periods of uninterrupted ovulation. Ibig sabihin, every time na nag-ovulate ka, nadi-disrupt yung architecture ng ovaries mo. Therefore, mas magkukos siya ng ovarian cancer. Okay? Pero, pinaka-risk factor mo rin are familial ovarian cancer syndrome with presence of BRCA gene and the HNPCC gene. Okay? So, there's family history of breast and or ovarian cancer, personal history of breast cancer, increasing age, early menarche. No, itong early menarche, infertility, and nulliparity, dahil yan sa history of long periods of uninterrupted ovulation. Go-ovulate ka ng ovulate. Okay? Tsaka tong late onset menopause. Obesity, BMI, more than 30. Okay? Protective factors, use of OCP, multiparity, breastfeeding, tubal ligation or prophylactic salpingectomy, and hysterectomy. Bakit itong tubal ligation or prophylactic salpingectomy? Because they found out that ovarian cancer, yung mga serous tumors, ito yung mga high-risk na ovarian tumors, comes from the fimbria of the fallopian tube as serous tubal intraepithelial carcinoma. Okay, so pag tinanggal mo yon prophylactic na fimbriectomy or salpingectomy, pwede kang makaprevent, pwede mo makaprevent ng ovarian cancer. Okay, so kung meron ka ng ovarian cancer, how do you stage? You stage it by complete surgical staging. So surgery. Okay, surgical staging is based on the operative findings at the commencement of the procedure. So ito yung staging natin. Ito hindi to galing sa blueprints. No, this is what we do talaga. You do laparotomy, you do peritoneal fluid cytology. Kasi dun mo malalaman kung affected ang peritoneum. Systematic exploration of the abdominal cavity kung meron ka ng implant somewhere else. No? Total hysterectomy with bilateral salpingo-oophorectomy, infracolic omentectomy, lymph node evaluation, random biopsy, RBP of the peritoneum and suspicious area, tumor debulking, appendectomy of mucinous adenocarcinoma. Bakit kailangan i-appendectomy kung mucinous? Okay? Kasi ang unloggy ng appendix at saka ng ovary, okay, pareho. So baka mamaya, appendix pala ang primary, tapos affected lang ang ovary. Okay? So pag ganon, stage 4, appendiceal cancer yun. Ang primary mo is your appendix. Okay? So this is the staging. Stage 1, ng ovarian cancer confined to the ovaries or fallopian tube, 1A, 1B, 1C. Dito, ang pinaka-importante nyo lang malaman is 1C, 1, 2, and 3. Okay? Pag 1C1, that is surgical spill. Ibig sabihin, yung OB, na-rupture lang niya during surgery yung mass. So that is 1C1. No? Pag 1C1, hindi pa kailangan talaga yung mag-chemotherapy. Pag 1C2 and 3, yon most probably kailangan na mag-chemotherapy. So sa management, nag-iiba-iba yan. Okay? So yun yung kailangan nyo dito. Kung kailangan nyo bang i-memorize lahat to, siguro i-memorize nyo siya mga 1 hour before. 1 hour before the exam. I-drawing nyo na siya. Okay, i-drawing nyo na. Pwede nyong i-drawing yung mga stages. Okay? Tapos 1 hour before, i-review nyo siya. Okay? 1 hour before, review. And then pagdating sa boards, dahil medyo fresh pa siya, pagdating ng OB, i-drawing nyo na siya agad sa inyong questionnaire. Okay? I-drawing nyo na siya para hindi na kayo malito. Kung may tanong man. Kasi minsan, wala namang tanong. Kung isa lang, tapos hirap na hirap ka talaga pumili kung ano dun, ibigay nyo na sa kanila yung 1 point. No? Kasi ang dami ng surgical staging, ang daming staging, ng lahat ng cancer. Bigay nyo na lang sa kanila yung 1 point. At i-wish nyo na hindi rin alam ng katabi nyo yun. Pero kung gusto nyo i-drawing, i-memorize, why not? Kung kaya nyo naman. Okay? Kasi kahit ako hindi ko pa siya memorize. Memorize ko lang yung mga kakaiba sa kanya. 3C, yan, na-memorize ko rin yan. Kasi more than 2 cms. Meron kasi ako nakitang ganitong case. So, nagiging 3C lang siya pag more than 2 cms. Pag less than 2 cms, 3B. Beyond the pelvic organs yan. Siyempre, pag 4, pag distant mets, alam nyo na, automatic 4 yan. Okay?